Hello and welcome to our Swedish Facebook Live. I'm Mona Locke. I'm Chief Communications Officer for Swedish Health Care System. And in our group, we have 5 campuses. We have more than 115 clinics, as well as 2 freestanding emergency departments. And we were on the forefront of fighting COVID when it hit Seattle. And we thought it was great to be able to offer to you, the public, an opportunity with some of our experts to ask questions live. So please feel free to chat in your questions as we progress. This week's topic, I think, is of interest to so many people out there. It's what's the latest in treatments, are there treatments, as well as what are the latest trials going on that we're participating here in Swedish. I've got a great panel of experts with us. So again, please chat in your questions as they come up, but we want to tell you about our panelists first and then talk about some of our success stories today. So we're going to start with Dr. Matt Hartman.
Hi, Mona. Thanks for having me today. So I'm an inpatient cardiologist here at First Hill. I also work on the Advanced Cardiac Support Service over at Cherry Hill. I also, in another hat, work at a nonprofit research institute where I have some exposure to some of these therapies that we're trying out for COVID. And for my part, I just want to say today that although there's a few of us here today, it's a huge team effort, and I want to big thank you to all of the frontline people in the ICU, all the nurses, the support staff, everyone that's helping take care of these patients.
I think you're so right, because so often those people who are behind the scenes actually delivering the care are not acknowledged so much. So thank you so much for that. Our second panelist today is Dr. Patel. If you could please introduce yourself.
Hi, thanks, Mona. So I'm Krish Patel. I'm the director of the lymphoma program at the Swedish Cancer Institute, and I'm a hematologist and oncologist. So I'm a clinical researcher and have come into the care of COVID patients and helping with the research efforts that are ongoing to care for these patients, as well as helping to think about how certain treatments we use in different diseases, like in cancer therapies, might have some use in patients with COVID. So thanks.
Thank you, Dr. Patel. We're so happy you're here. And our final guest today is Dr. Murray. If you could introduce yourself.
Thank you, Mona. I'm Cynthia Marie. I'm one of the infectious disease specialists here at Swedish, and I'm currently heading the subcommittee for our PNT for pharmaceutical and therapeutics on COVID. So I've been here for about 8 years, and I cover 4 of our campuses.
Great. And we're trying to practice our physical distancing, so you won't see us all together in one room and just individually speaking. So bear with us. So I wanted to start today talking about treatments, because in the Wall Street Journal just this week, there was some coverage about Swedish and a patient that we treated who he was critically ill and he recovered, and he was actually the emergency department doctor on the forefront of COVID at Evergreen Health when COVID hit Seattle. And he has given us his permission to talk about his case, because we think it's so amazing, and we're so happy for all his hard work he's done in this field and the fact that he is fully recovered. I want to start with that because he came to Swedish in critically ill condition. And Dr. Hartman, if you could start out and just fill us in on where we went from there.
Sure. So I think on everybody's mind is, if they get this illness, how sick will they be? And the large majority of people, I think the numbers currently are 80%, will have just mild disease. But we're seeing a few patients that get profoundly sick. And in those patients, they can get sick very, very quickly. And this is actually what happened with our patient. In a matter of 24 hours, he went from breathing on some room oxygen to requiring a ventilator and some advanced therapies. And from there, he continued to get worse to the point where we needed to use something called ECMO, which stands for extracorporeal membrane oxygenation. And the way you can think about it is it can function like a heart-lung bypass machine, where we can take over the function of oxygenating the lungs. And his lungs were functioning so poorly that that's what we had to do. It's used rarely in these cases. When people get so sick, sometimes we need to do that. The question we asked ourselves when he got here after starting that therapy was, what can we do next? Because that's kind of the limit of the technology we have to help these patients. And that's when we started to explore the other ideas of, is his immune system overreacting? Is there something we can do to help with that and see if we can improve him?
So at that point, you really there's not much more we can do that's conventionally
Yeah,
known?
you know, the technology kind of stops there. We can only do so much with machines, and the body has to heal itself. And what we're thinking, although this is a very much of a speculation, is that these patients that get really, really sick quickly, that the immune system and the inflammatory response is so profound that it's damaging the body. That also helps fight the virus, and so it's a very delicate balance whether we can intervene, and if so, who we should intervene on, and what we should use.
And Dr. Patel, would you like to talk a little bit about where you went from there?
Sure. So as Dr. Hartman mentioned, you know, there's this thought that in some patients with COVID, some of what we may be seeing causing this very, very rapid sickness is due to the immune system, and perhaps the immune system is behaving in a disordered way. We see this in other diseases. There are several hematologic diseases that we see this in. There are several other infectious diseases that we see sometimes this occur in. And one of the things we have experienced with at Swedish is a special type of cancer treatment called CAR T-cell therapy, where we actually see this treatment cause a dysregulation of the immune system that causes people to become very sick and have problems with breathing and oxygenation. So there has been some research from China that suggests that perhaps medications we use in these other illnesses could have a benefit in some patients with COVID-19. And so really in a team effort, after kind of thinking about this patient's case, we thought that this patient may be an appropriate patient to try this kind of treatment in. And so we were able to do that. And, fortunately for this patient, it seemed to have helped them. I think Dr. Hartman's point is a really important one, which is there's a really fine balance between calming down the immune system in patients in whom it might be causing problems versus, interfering with the immune response, which is necessary to help clear infections.
I mean, you must have been so surprised in this, and I'm wondering how long did it take for him to really start turning the corner, and when you realized that this was happening, what were your reactions?
So that question is to me. I'll take it. We were watching him constantly. Even you can't say day by day. I mean, this was hour by hour watching how he was doing. And I'd say right around day 4 or 5 of getting this therapy is when we really started to see a change in his body's ability to oxygenate himself. His lung function was getting better. And we were able to get the ECMO circuit off within it was 160 hours. We measured it to the hour, which is, it sounds like a long time, but a lot of these patients, if they need ECMO, they can be on it for weeks at a time. And 4 days after that coming out, he was off the breathing machine. And so he had a really rapid improvement among other therapies we used as well. It was wonderful to see. The team is ecstatic that he's done so well and he's been able to leave the hospital.
That's wonderful. And we have our first, one of our questions here that says, we've used Toxi on a lot of patients. Is that what you're referring to, Dr. Patel?
Yeah, so the medication we used for this patient was called tocilizumab, or the short name that people give it is Toci. And it is a medicine that targets a particular pathway in the body that is used to kind of activate the immune system. And so that's the medicine that we're talking about here.
And the patient has returned home.
Yes.
Can you tell us a little bit about the timing of that and how quickly this turned his case around from a point where he was critically ill and we didn't know what more we could do for him to him actually walking out the door?
Yeah, it's still amazing that I think it counts as hospital day 24, so he was still in the hospital for 24 days. That in and of itself, we know patients that don't even get this sick, they can have the virus in their system for 3 weeks or 4 weeks or longer. The turnaround from requiring essentially the limit of support that we can provide people, meaning up to ECMO and ventilation, and also renal replacement therapy, meaning his kidneys weren't working and we had to take that function over as well. Within a week, we were seeing a large improvement, and shortly after that, he was off the breathing machine. So it was a matter of less than 2 weeks that we went from him being critically ill to him being out of the ICU, on the floor, breathing on his own, and continuing that recovery process.
Yeah, it seemed to recover so quickly because he was supposed to be released on a Monday and he was actually released a day early from what I understand.
Yeah.
right? And so is this something, if I'm out there listening, I'm going, wow, there's a treatment. Is this something that can be applied broadly, or how do you make those decisions?
I think from my perspective, I think it's a very careful decision with a team approach of getting all the experts involved from infectious disease. Our colleagues in hematology, oncology have experience with these drugs from the side on cardiology and supporting our pulmonary critical care doctors, everybody involved, because it's a very delicate decision, again, about are we going to cause harm or are we going to help? And that is a very fine line to walk, especially when these therapies, as everybody knows, they haven't gone through clinical trials yet. This is all very fast and new, and this information is coming out, so it has to be thought through very carefully. Not everyone who walks through the door who has this illness should get these therapies, because again, 80% of people seem to have a mild case, so you wouldn't want to give them a therapy that might have some risk if they're going to do fine without it.
So, I just think it's important for folks out there to know that is it just critically ill people then that you would consider this treatment for?
I think maybe Dr. Patel can weigh in on this and some of the registries and things that they've created rapidly, which is kind of amazing how fast they got this up and running to watch this and answer these kind of questions.
Yeah, so I'll take a stab at that question, and then I'm going to turn it over to my colleague, Dr. Maria, in infectious disease. But I think there is this probably group of patients where we can see that they have a very rapid progression of their breathing difficulties, and that subset of patients seems to be a category where maybe this kind of medication has more benefit, because the kind of speed at which these changes are occurring may be telling us that perhaps this is due to the immune system's response rather than the virus itself. Do you think, Cynthia? Mary?
I think that's exactly right. Do you want me to kind of go
Yeah,
into
sure,
some
that
of the...
would be wonderful.
Yeah, so I think some of the challenges that the team is elucidating here has been how to go through all the information that we're getting on a novel virus when there's not a proven treatment, and how to best implement that in a safe way for our patients. And that's been the process that we've tried to create here at Swedish. So we're getting this information coming from China, Italy, and other places that have been dealing with the virus a little longer, is starting to put out a great deal of data for us to evaluate and see what we think holds merit enough to actually offer it to our patients. And preferably, we would like to try to not use all these therapies off-label, but in a clinical trial, so we can gain some information about what therapies might be useful. It's a challenge to do that when we don't know the long-term side effects of the therapies we're using, and whether patients would have gotten better on their own without any of the risks that are involved with therapies. So I think Swedish is doing a great job, and it's definitely been a multidisciplinary approach, which has been super fun to work with all of our colleagues really closely in hematology, oncology, cardiology, pulmonary critical care, and infectious diseases to really have a team approach with this. We also work really closely with our hospitalists who are day in and day out taking care of these patients to identify the patients we think are most at risk for having adverse outcomes in this disease process, and then looking to see what therapeutic options we would consider in an off-label or in a trial situation. So would you like me to go through?
You've kind of touched on it, and I wanted to delve deeper into the fact that you are a part of a subcommittee on COVID that was created shortly after the pandemic hit. So if you could talk more about that partnership, and it kind of couples with another question we got here. It says it sounds like a large number of physician caregivers came together to develop these unique treatment approach from different disciplines. How do all these health professionals come together so quickly and so effectively? And what this viewer says is that level of communication is impressive. So if you could just expand on that a little bit. When COVID hit, how did this happen?
You know, I absolutely agree with that comment. I think the level of collaboration within our hospital system has been higher than I've ever seen it. I think people really came together in the crisis mode and tried to figure out how to work together to sort through all of this and provide the best care we can. And one of the things that I've been just amazed at and thrilled at is to see the level of survivability within our institution for COVID disease has been remarkable. And that is really not just one therapy that we're offering, but it's a team approach for taking care of these patients. And some of the new strategies that we're coming up with for treatments, we currently have in our hospital a randomized, not randomized, but a trial that is on for remdesivir, one of our antivirals. We will probably be having another trial coming on for hydroxychloroquine, which has been in the news a lot, but to actually do that against placebo to have an idea of if this is making a difference in the inpatients. We also have Dr. Patel is heading up the trial for tocilizumab, which will be done in a randomized controlled fashion, so we can have some information about whether this is beneficial for everybody. And then we will also be having the convalescent plasma coming on next week in one of our trials. So we're really excited about that to come on board here. And patients who have been exposed with COVID prior can already start contacting the Northwest Blood Bank, Bloodworks Northwest, sorry, for making donations. We have a requirement of being over 18 years old and having been at least 28 days since your positive test. And then we have also a vitamin C trial, which should be coming on board, and that is for our more critically ill patients with acute lung injury or ARDS. So it's a very exciting time for us to try to help guide the world and community about new therapies, and we are definitely on the forefront of that here at Swedish.
And I guess one could ask the question, well, we're in Washington State, by the way, which I forgot to mention in the beginning, but we're here to serve patients, right, with our 5 campuses and all these clinics. So how do we find the balance between getting involved in the trials and treatment, the trials that we are, and actually delivering the care to the patients?
Yeah, it's a very good point. And I think that that's one of the things our P&T committee was formed specifically for, to try to keep the patient at the forefront and try to figure out which options are best for each patient. And we're trying to provide information to the providers who are seeing those patients individually to give them information about what is available and what we would recommend, and then allow them to guide their treatment options based on that patient.
Yeah, it was a pretty scary time, obviously, and we all hear that it's kind of, the curve has flattened in Washington State. We still hear about COVID throughout the country and these outbreaks. And so should we relax and feel better now? I mean, we have the governor saying stay home, stay healthy. I think it's easy when you get to this point that you start relaxing and saying, yeah, it's not so bad here. Any thoughts?
Well, we're still extremely busy with it.
Yeah.
So, I mean, although we did not get the bolus we were afraid of and feared, we have had still steady amount of patients coming in. So I don't think the threat is completely gone yet. It's still there. And we've been thrilled at the community response and the ability to control that bolus from not happening. That would have been devastating to our community and our system. So the fact that everyone is out there making those efforts to do social distancing and do what they can to stop the spread of this virus is so important to the success we have as a community.
Yeah, I think, and we've actually started this campaign here where we say physical distancing, because for the behavioral health side, we really don't want it to imply social distancing, because as we know, everyone's using all the different electronic means and Zoom and Skype and Teams in different ways to communicate and still gather as a community. And so we like to say physical distancing for those of you out there. Also, in terms of current patients, I'm going to throw it back to Dr. Patel and Dr. Hartman in talking about the treatment that was successful for the ED doctor at Evergreen. You have other patients on this trial as well, or treatment?
Yeah, so through Dr. Patel's efforts and Dr. Pagel, I've never seen, I got to say in all this, I think we're all the same, I've never seen medicine move this rapidly with changes that are happening by hour, by day. One question came up about how do you form these committees and how do you get all this communication? We just had so many meetings through teleconference, and just it consumed the day to communicate with everybody, and I've never seen that. It was really impressive to be involved in that. What they did was they created a registry so that we can capture information on patients who might be treated with these therapies. In full disclosure, I think it's important to point out that our patient who did better, he got tocilizumab. He also got high-dose vitamin C therapy after it. He was on these other therapies that are being explored, including hydroxychloroquine. So there's a lot of therapies involved. But there's now this registry, at least for the anti-cytokine therapies, tocilizumab being one, so we can capture data. And as Dr. Murray pointed out, there's these other trials that are ongoing to capture patients that are on these therapies and see how they do. So yes, there are other patients that have been treated with, I know, tocilizumab in particular. In addition to these other therapies, these are ongoing efforts, trying to get that information out there as quick as possible as well, because the information is changing by the week. I mean, it really is. We get new data within a week to find out that is something working or not, and it's really fast how things are changing.
Dr. Patel, also, we'd be remiss if we didn't bring Dr. Youssef into the conversation, because I know it was the three of you, Dr. Youssef, Dr. Hartman, and Dr. Patel, who really came up with this idea to treat him with this drug too, Actemra, that we haven't really, if we touched on this. And Dr. Patel, do you have any comments really about the treatment that continues to occur with these other patients who are severely ill?
Yeah, I think I just reiterate a point that Dr. Hartman brought up and that Dr. Marie did. It's really a team effort. There are so many people who are involved, and not only the physicians and the nurses and the frontline healthcare workers, but we at Swedish have a very rich tradition of clinical research. So we have clinical research staff and teams who help us be able to do this in a very organized way. So as Dr. Hartman mentioned, we really need to study the effect of treatment
to accomplish, and really the timeline that happens.
I just don't understand the question. The timeline
of the treatments, like how long would it take from, the trials, from the trial period to actually get it to be medicine and be able to be administered to COVID patients?
For approval as a treatment. Yeah, I think that's a ways down the road until we have more information about the randomized controlled trials and can look as a regulatory body about what treatments we're going to recommend more on a national level. But as far as using the treatments now, when our patients walk in the door, if they qualify based on inclusion or exclusion criteria for treatments, they will be able to receive those immediately.
Yeah, and in general, I guess the question was how long does it take from, and I know they're all different types of trials, but from the point where you start the trial to the point where it actually can be sold over the counter. And there's just so many different trials that you mentioned on there. So I'm wondering, is there one that's closer to fruition and to the end point, you think, than any others, or what can we anticipate?
Yeah, I don't think so. And we are still, this is so new, and we're still in this phase where we're just trying to gather information. So just getting the trials out there, getting people enrolled, providing the data so we can start looking at it to really know in a controlled fashion which therapies would benefit. And I don't know nationally if we have trials out there that are further along than where we are. I mean, I think it's going to be a number of trials out there coming out with information, and it'll be a process over time that we'll have a better idea of exactly which treatments we can recommend. But currently, we don't have any proof that one treatment is more beneficial than another, and that there's a treatment for COVID. We don't have any information that treating with anything is better than not treating. These are the things we have ideas, but we don't have proof. So that's what we really need.
And let me ask you this, with all the different trials, how does one decide to do a trial, or how does that come together that we're actually going to turn it into a trial?
Yeah, that's interesting. I think a lot of that comes from the bench work and really looking at the microbiology behind it, what we think would be effective therapies, and then people looking at the risk-benefit profiles of those therapies, and then coming up with ideas of actually trying to use these for a certain treatment. So it's really bench-type science to bringing it to the patient level science.
And I would say in the U.S., we're really one of the first places to see a lot of COVID patients, but we're very, very fortunate that our colleagues, scientists and researchers in China and Italy, despite facing really difficult circumstances, have made an effort to publish information that would then be helpful to those of us who are seeing this disease and illness later. And so a lot of what Dr. Marie mentions about that science really comes from, people who were facing this much earlier than us in China and Italy, and without the work of those scientists and researchers, it would be even harder to design clinical trials that would be potentially helpful to our patients. So we owe a lot of credit to those folks as well.
Yeah, that is exactly right. It's kind of a snowball where we're picking it up as it's moving around the world and hopefully building on that knowledge in a very collaborative way throughout the world. Yeah.
Thank you. Thank you so much for your participation. We're just about out of time. So what I normally do is I do a round robin and I say, give me your last words of wisdom to those out there. I'm going to start with Dr. Patel.
Yeah, so my best words of wisdom would be the best way to treat a disease is to not get it. So keep doing what you're doing, and the physical distancing, I think, is working. So thank you for everybody's efforts there.
Perfect. Dr. Marie?
Yeah, I couldn't have said it better. I totally agree. The physical distancing is working. We are very happy with current conditions here in Seattle, and I hope that it continues.
And Dr. Hartman.
And from my perspective, from the cardiology world, I think that relaxation is great. So good for your blood pressure, so relax. However, be vigilant in everything you're doing and don't be lax in all of those things. But relax for yourself and keep up the good work out there.
That goes to our wellness conversation from last week. And also, just the message from me is to make sure you stay vigilant about staying home and keeping those distances. But I would remiss to say that, you've done such a good job that our emergency departments, from what I understand, actually are able to serve other patients who have emergencies and not just the COVID patients. So that's a good point to note for this week. Thank you again for joining us, and we hope to come back to you next week in our Swedish Facebook Live.